أروى.
ازيك يا برو؟
السلام عليكم، إن شاء الله كويسين.
وعليكم
كيفك؟
السلام ورحمة الله. بخير حالكم؟ Yes, we can start.
Shall we start now?
Okay.
بسم الله الرحمن الرحيم. Welcome. مرحبا بكم في هذه المحاضرة. كاريبو من تنزانيا, و it is about continuation of tuberculosis. This is an important disease, tuberculosis or TB. Okay. ويعرف بالعربي بالسل. This was a stigma for people who get tuberculosis because there was no treatment. These people are sanatorium patients, that is to say, they are being kept away, away from the patients and from the cities for two reasons. One is they should not infect others. Number two, they think that fresh air and good nutrition will help the cure. This is before the advent or invent of the drugs, which is now very effective. So it is a disease which is still with us, despite the fact that we have very efficient, highly efficient drugs which can cure an individual patient and can prevent transmission. However, it is not just a drug. When it is a drug which has to be swallowed, it's a multiple drugs. It's a long period from 6 to 9 months. So it is a complicated regime for treatment. Okay, if you have a drug for 7 days, you may still forget one or two, and this becomes poor compliance. But if you have a drug, like 4 drugs or 3 drugs, the high likely that you can miss these drugs. And missing here is something we think is dangerous, because it doesn't only disturb the treatment and the outcome of the cure, but it also precipitates resistance. And resistance is the word which we fear most with tuberculous drugs, because now we have multiple drugs which are available, which can be very, very effective. But once we don't take the drugs regularly, or we take it for a shorter period, then the bacteria will get resistant. Very common bacteria, and we have seen that it can be in the latent period, stays for years till immunity is suppressed, and then it flares up as tuberculosis. So resistance is the buzzword for fear. Resistance is a buzzword for fear. And luckily, now we are using 4 drugs, or at least 2 at any time, for giving the assurance that there is no resistance. Okay, resistance occurs either by mutation of the genes, giving the bacteria an extra defense mechanism, like thickening the cell wall so that the drug cannot penetrate, or changing enzymes, or producing enzymes which can inactivate the drug. So this is nature. This is nature, that bacteria have to survive, and this is one way that the bacteria can survive, by development of the resistance to the enemy, and the drugs are the enemy of the bacteria. Major advances has been achieved in the field of tuberculosis, but still there is now 10 million, at least 10 million people who are taking anti-tuberculosis drugs, and we reckon that 1.7 million every year die because of tuberculosis. All right. You have to mention that in before 1944, there is no drugs, nothing. All people will do is to isolate, to put in sanatorium, and give good air and nutrition. It is still believed that good nutrition and fresh air can help treatment, but they cannot be the sole treatment for tuberculosis. So it's 1944, streptomycin was introduced, and it very quickly, like a new drug, it cured some patients. But as years gone by, because it was a single drug, resistance developed. In one study, very soon after 1 or 2 years, 35 out of 41 patients being treated developed resistance to streptomycin. And in a long term, like 5 years follow-up, the mortality from no streptomycin and from patients who receive streptomycin is not very much different. So this is a message we got from treatment of tuberculosis, that this is a cunning bacteria which can develop a lot of resistance. So please remember that the patients need support, and this support comes in terms of education to the patient, education to the family, education to the community, and social protection. That is the aim of all this, is that the patient should have the treatment number wise every day and duration wise for a month, for the duration of the month, without interruption. We have problem if the patient suddenly stop the drug and he come after 1 month for reinstitution of the regime, then we have a problem here. And patients with those who stop the drugs has to be examined to bacteria being cultured, and susceptibility to antibiotics has to be confirmed because resistance may have developed to the old ones. So it is that important. Okay, so it's in the MRC, which is the Medical Research Council of England, have done quite a lot of work from 1948 to 1986. They helped one to identify the drugs which come on and test their efficacy. Number two, the combination of the drugs. Three, the duration of treatment. This is a complex problem, which uh, fortunately the MRC has really produced good data on that. 1948, if you remember, is the day when WHO has been born. It used to be the League of Health. Before the WHO, it used to be the League of Health. But in 1948, the WHO was born. And this is the same date, 1948, when the National Health System of Britain has been born as well. So 48 is an important time for the health professionals. Okay, so the MRC has led quite a campaign of clinical trials, and which ended up with a good recommendation, but they closed the file in 1986, which is the wrong year for closure, because that is the year when we discovered that HIV/AIDS is a twin of tuberculosis. They have very close relationship. And secondly, 1986, more of resistance has been creeping on. Okay, so the drugs has been developed very well. We know now the combination is very good, and we know how the combination can help. Okay, a major development is diagnosis. Diagnosis, classical diagnosis, the reference diagnosis, seeing the rots of bacteria of tuberculosis on in the sputum. But there are other tests which are PCR, what we call nucleic acid amplification test, NAAT, and one of these tests is gene X capital X pair, X pair. This is will tell you if tuberculosis is there. So we have good tests nowadays for tuberculosis, which is very good, and we can even test the latent tuberculosis, as we will come to that. So the third development is now the vaccine BCG, which is it's an intradermal injection of PPD, which is purified purified protein derivative, which is an antigen. If you inject an antigen, then antibodies, lymphocytes, humoral, and cellular immunity will develop and causes a wheal. It's not redness, it is a wheal. It's a rounded structure. You can even feel that it is rounded and above. And this is the MAN2 test, what we call MAN2 test. It is a purified protein injected. In children, we can use Hive test, which is a gun with multiple needles, and then it goes in superficially in the skin, subcutaneously, and then inject the purified protein, and then causes the induration in children. So this MAN2 test or tuberculin test is important in determining if this patient has previous tuberculosis, has latent tuberculosis, or active tuberculosis. So it's the differentiating power of this into these three categories of tuberculosis is not very good. But at least it will show that this patient has been sensitized by tuberculosis either in the past or in the present. This is the MAN2. Okay, WHO has been very careful about developing, a lot of guidelines for treatment, for strategy, for prevention, and for elimination of tuberculosis. All right, the word elimination we cannot use it because it's far from being achieved, because this is a continuous disease, and with immunity being suppressed for any reason, particularly HIV, then that disease is going to continue with us for quite a time. But the WHO in 2016 have put a strategy, which is called the 2016 to 2035. During this period between 16 and 35, they put a strategy for end tuberculosis. End is a loose word. End meaning reducing the tuberculosis to a major level, which is not elimination. So the pillars, they have three pillars, okay, for end of tuberculosis. The pillar number one is early diagnosis, and this is goes without saying, early diagnosis and early treatment, because one of the factors which increase transmission is open tuberculosis. Open tuberculosis meaning that it is lung, and if you cough it out, you cough TB bacilli, and then this will increase the transmission. So this is open tuberculosis. So early treatment, then it is very important, because any day you get out is a beneficial day for less transmission. And we said that in 2 weeks continuous treatment for drugs, then the patient may not be infectious. And this is one of the turning points in treatment of tuberculosis. Now, tuberculosis is not an inpatient treatment. It is an outpatient treatment because of in 2 weeks' time, if he is kept in house, then the patient will not be infectious. So the pillar number one is early diagnosis and so early treatment, which is important. And this is why we are going to use not only the microbiological, which is testing by Zell Nielsen stain, but also by the amplifier of the PCR gene expert. Okay, the second thing is you have to do susceptibility test. That is part of the pillar number one. Susceptibility to see that the patient, if possible, culture and response to treatment. If it is sensitive to this anti-tuberculous or not. Then screening for resistance. Screening is different from susceptibility. Susceptibility is you have a patient, you test the microorganism for resistance or for response to antibiotic, and you know that this is being done in a dish where if the antibiotic is effective, then it kills the bacteria. But the screening is an epidemiological test, which has its rules, and you pick up certain cases on randomization table, and then you examine for susceptibility or resistance. Okay, the third point in pillar one is the close treatment or close collaboration of doctors who are dealing with HIV and TB. Luckily, in Africa now, TB and HIV is being put in one department, which is very logical. Okay, but there is an interaction between drugs for ART for HIV and for tuberculosis. We'll come to that when we talk about drugs. So it really needs somebody who is very good in handling the drugs and seeing what are the side effects, what are the interaction between this and that. But it is advantageous to have tuberculosis and HIV being in one department. Okay, so the second pillar of end tuberculosis is obviously political commitment, and this is a disease which is very devastating. It has high mortality if not treated, but it requires multiple drugs which are expensive, has to be provided free for these patients, and it needs a follow-up, very close follow-up. And when we talk about DOT, which is directly observed treatment, then it requires a program. And this program involves the stakeholders, not only the family, the patient, and the social worker, but also it involves NGOs, non-governmental organizations, others, who can pick up the patient, who can deliver the patient to the hospital or to the center, who can help educate the patient. So it's a complex treatment. It's not like a 1 week treatment, which you can do for easily, but it's a complex treatment. Okay, so you have to link all these TB control. Usually there is a department of this type. Okay, and all stakeholders should be in that part to help guarantee that the patient comes to the treatment or takes the treatment. Number one, number two, is swallow the tablets. It's very important. This is adherence to the instructions. Okay, and then you have to have social protection. social protection for these patients. WHO will advise that the governments should provide at least help. Okay, if the government cannot help, but socially oriented NGOs, which is non-governmental organization, or philanthropists, which are good wishers, could help us. Donation of food and drug, for food and facilities, then it is important that these patients will get social protection, because malnutrition is definitely a risk factor. Stress is another risk factor. Um, Eating the wrong items is another risk factor. So this is what we call social protection. I'm just giving you what is the WHO is recommending, okay? And then you can see this scale to put in each country if they can do it or otherwise. But this is the complete package. Now, BCG has to be provided, which is the three for vaccination for all neonates on the first day on their birth or at birth. And remember that if you give BCG, don't give other vaccinations except after 2 weeks from the BCG. Okay, measles, rubella, whatever, polio. Don't give any vaccination except a lapse of 2 weeks from BCG, and BCG is better given at birth. Okay, then pillar three is intensifies research. We have now the good drugs in hand, and we have at least 5 or 6 drugs in development or already like a second line drugs, because we are going to talk about resistance and what we call MDR and XDR and TDR. Okay, the resistance. Okay, this is why we have to have on the shelf, some standby drugs, which if any resistance creeps to these classical 4 or 5 drugs, then you can use the second line drugs. So MDR is multiple drug resistance. And this is by definition is resistance to the two major drugs, which is rifampicin and isoniazid, INH, isoniazid. Okay, so if you have resistance to that, then you have MDR. All right. If there is extensive or extreme resistance, then it is XDR, and it is plus 2. You have one of the fluoroquinolone, and one of the injectable antitubercles like amikacin or gentamicin, or these are the streptomyces derivative. Okay, so if you have 2 of the major and then 1 from fluoroquinolone and an injectable one, then that is XDR. XDR. Okay. TDR is total. That is, no drug is effective at any rate against that bacteria. And this is extremely dangerous. Even the MDR is dangerous, but XDR is extremely dangerous. And these patients has to be treated in a closed area where the siphoned air can go up to the sky. So and even nurses who are nursing those patients should have a protection. Okay, treatment is the major 2 is rifampicin and INH. Okay, we'll come to the pharmacology of these 2 drugs, isoniazid and rifampicin. Isoniazid is tuberculostatic drug. It has no effect against other bacteria. So it is lucky because if it is used as an antibiotic, people will start using it for non-tuberculosis and get resistance to tubercle bacilli. So it is isoniazid, which is isonicotinic hydrazide, isonicotinic hydrazide, INH, or isoniazid, which is being given in tablet form, and there is now a syrup form for children. So isoniazid is the best, is the top. Okay. Number two is rifampicin. Rifampicin is an antibiotic, and okay, it's very effective now, but because it is used as an antibiotic in other conditions, we fear resistance. And we always teach that rifampicin should be reserved for tuberculosis. Okay, streptomycin very quickly bacteria develop resistance to streptomycin. Nowadays, we don't advise giving streptomycin to any infection, so that it is in the pipeline. I mean, if we need it, we can find it. But the resistance is difficult. Okay, as we said, regularity in treatment is important for cure. Regularity of treatment is important for not developing resistance. Okay, and this is why they invented the DOT, which is directly observed treatment. Directly observed treatment is give a big dose for three times a week, 3 times a week, and this means that the patient will come to the clinic, is being observed to swallow. Once he swallows, he goes home. Okay, this entails that there is somebody waiting there for him, somebody to dispense water to be given, swallowing to be done. Okay, it's a procedure. Okay, but it really helped because it maintained at least a good level of drugs in the body. And one study has shown that using directly observed treatment have decreased the prevalence of tuberculosis, or sorry, the cure of tuberculosis from 57 to 87%. So it worked, but it is a difficult procedure. Okay. Nowadays, we don't think we need DOT. Drugs has to be given regularly, every day, but we can observe. We can observe by medicine technologies. The medicine technologies, people now have mobile phones. We can get somebody who sits there and start phoning the patients to see if they have taken the drug, or SMS, okay, or digital medication monitors. And there is now, during COVID, we learned quite a lot about these new technologies in monitoring drugs. Okay, it is digital medication monitors, or even video observed therapy, VOT, video observed therapy. So it's, if the patient will just put it in a video and send it to us, we know that he has developed. So we don't need to come physically face to face, but we can do it online. And this is a new development which can be, all we are after is to get the patient to swallow this big chunk of drugs, big chunk of drugs. So it's, remember, uh, remember that patients who have liability or susceptibility to tuberculosis, because we are going to talk about chemoprophylaxis. If you are so exposed and you're going to get, okay, tuberculosis, high likely, we can give you protection by INH or isoniazid. So age, elderly people are more prone. Alcoholics, again, are more prone. Active smoking, this is a predisposition or make you more susceptible. Diabetes, okay, poverty, pollution, deficiency of vitamin D, silicosis, okay, This is an occupational therapy. Okay, pneumoconiosis, any cause of immunosuppression, but by and large HIV. If the others one is the risk ratio is about 2.6, for HIV it is 20. It is 20, 10 times, say, the prone of diabetics. If diabetics are prone to tuberculosis, then the patients with HIV are 10 times more prone. Okay. You remember the MAN2 test has to be read, okay? Has to be read, and this is accepted level 5 millimeters in immunocompetent, but 10 millimeters or more is in HIV is seen to be positive. Okay, so it is in HIV. It is all tuberculosis has a different parameters. Have a different parameters. Okay, the treatment. What are the goals of treatment? Aims of treatment is one, cure. Okay, for an individual patient. Number two, prevent dissemination or transmission. Number three, combat resistance or prevent resistance. Okay, so it is, and these are the guidelines for treatment, which should be followed closely. Should be followed closely, and we follow it by, okay, smear positive becomes a smear negative. It's very important, and we do it after 2 months. We do the smear testing after 2 months. Okay. Number two is resistance, and this can be done by culturing and testing sensitivity or susceptibility of the patient or bacteria to the antibiotic. Okay. Transmission is by prevalence surveys. Okay. If I'm doing good prevalence surveys or screening, then I can pick up the positive and the degree. Okay. Latent tuberculosis is not very easy because often in children, it's an infection, usually in the apex, all right, and then there is lymph nodes affected, maybe in the higher lymph nodes or peritracheal, and this is what we call the primary focus. This is the latent tuberculosis, and it's called also in old books Ghon's focus, capital Ghon, Ghon's focus, and it passes unnoticed. Most of those who are living in tuberculosis prevalent areas they have latent tuberculosis. Okay, only in 5% of them, in children, they get disseminated. They get disseminated tuberculosis from the primary focus, but otherwise it's a latent tuberculosis. In X-ray, it can be shown that there is a small scar with a lymph node. Lymph nodes are very linked to infection with tuberculosis because they may have tuberculosis, lymphadenitis by themselves without being secondary. Okay, how would you detect latent? Okay, there is an new assay called interferon gamma release assay. Interferon gamma release assay. Capital G, capital R, capital A, capital S. And this is an assay getting interferon gamma released, okay, for mononuclear cells. And this is an assay can determine the threshold if the patient has latent tuberculosis. Okay, so the drugs we are using is by and large, the main ones is one INH, which is isoniazid, and isoniazid was discovered in 1952, 1952, and still is the drug of choice in tuberculosis. Okay, and rifampicin is these two drugs which are available, which are very highly effective, if you call primary drugs. And then you have pyrazinamide, pyrazinamide, okay? And then we have ethambutol. We can play with these four drugs, okay, for a period. We started with a 10-month treatment where you have para-aminosalicylic acid and streptomycin for 18 months. Then it was decreased to 12 months, and then it was even decreased more. Okay, I will give you now the duration which is now recommended by WHO in 2017. So it's not far away and it's still holding. The treatment should be daily. We already stopped the 2 times a week or 3 times a week. It has to be daily. For 2 months, you give 4 drugs: isoniazid, rifampicin, ethambutol, and pyrazinamide. You give them for 2 months continuously, 60 days. And after the 60 days, we do a smear. And usually it goes from smear positive to smear negative. Okay? Following that, we follow 4 months with 2 drugs, with the major ones, which is isoniazid, INH, and rifampicin for another 4 months. And this has been shown to be as effective as any long therapy. Okay? The only exception is in some authorities is tuberculous meningitis and cerebral meningitis. For this, penetration is not all that good, all right, and you need treatment for long, and you go to 9 months. Some people go to 12 months. But if you remember, 6 months initially, 2 months are four, and then 4 months, 2, that is for the general tuberculosis, be it lung or be it lymph nodes, all right? But for tuberculous meningitis or tuberculous meningitis or cerebral tuberculosis or bones like Pott's disease, then treatment should continue for 9 months. Should continue for 9 months. So this is important to remember. So it's easy, it's becoming easy, okay? Very easy to give all these drugs where we have good control. Okay, there is a phenomenon which is funny. It is called paradoxical treatment. Paradoxical treatment is paradoxical, meaning not to expect it, the opposite. If I'm giving you drugs to reduce the temperature, then the temperature goes up. This is paradoxical treatment. Okay, so with these drugs, sometimes you can get worsening of the condition, particularly lymph nodes. You get larger, the lymph nodes will enlarge, they become tender, fever is there, and then this is then subsides, and this is a paradox. What to do with it is just to continue the drugs. People have advocated corticosteroids, but the evidence is weak. Okay, so paradoxical treatment has to be dealt with very carefully, and the patient should be given enough support during this paradoxical treatment. Okay, so the drugs, INH. INH is isoniazid, hydrazine, and this is the hydralazine derivative. Hydralazine derivative. Okay, it comes in tablets form. Okay, the dose is
بروف الصوت اختفى.
by phase two metabolism, which is you remember we have phase one metabolism, phase two metabolism. Phase one is hydroxylation in the liver in the microsomal enzymes. If you remember them, these are microsomes rounded particles which contains a lot of enzymes inside. It is in the smooth endoplasmic reticulum. Okay, the rough endoplasmic reticulum is the one which produces albumin. So we are restricted to the smooth endoplasmic reticulum, which have these spherical microsomes, and then within these microsomes there are enzymes which metabolize chemicals, including drugs. So, and then the phase two, the phase one is hydroxylation, oxidation, and reduction. Reduction is H, adding an H. Okay, phase two is conjugation. You conjugate by phosphate, acetyl aminotransferase like hydralazine or INH. So it is phase two. And INH is metabolized in phase two by adding hydryl acetyl group by the enzymes acetyl aminotransferase. So it goes in phase two, but it has a cunning way of going back into phase one. The acetylated metabolite is then hydroxylated. And this is important in enzyme induction because the second phase is not enzyme induced. The first phase is enzyme induced. Okay, so it is first acetylated and then hydroxylated. And one of the side effects of INH is hepatitis. And hepatitis is caused by the hydroxylated acetylated molecule. So if you have an enzyme inducer, then it will help development of the hydroxylated acetyl group, which is the hepatotoxic. At any rate, this is the acetylated form, and certain people have fast acetylation, certain people have slow acetylation. Okay, in Sudan, we have mostly about 78% are slow acetylator. And slow acetylator are the ones who have more side effects. But it is marginal, it is very marginal. Okay. What are the side effects of INH? Number one is hepatotoxicity. Okay, hepatotoxicity can cause hepatitis. All right, and by and large, all three drugs, let's say for sure, which is INH, rifampicin, and pyrazinamide. These drugs, all three can cause hepatotoxicity. The most which causes hepatotoxicity is not INH, is not rifampicin, it's pyrazinamide. Okay, so they all cause hepatotoxicity. Don't worry about slightly raised transaminase with these drugs. This is not a big problem. But once the patient has 10 times, or 20 times transaminase with symptomatology of hepatitis, then this is a serious side effect, and we have to stop the drugs and wait, and then reinstitute the drugs later on. The other side effects of INH is peripheral neuropathy. And peripheral neuropathy can occur in normal, healthy people, but also is more prone in patients with malnutrition and those who have diabetes. Okay, this is a peripheral neuropathy which responds to pyridoxine, which is B6. Why? Because INH will inhibit the pyridoxine phosphate formation, which is a pyridoxine kinase, or phosphokinase, which transforms INH into the metabolite of 5' pyridoxine phosphate. This is the active ingredient. So if it blocks it, if INH blocks this, then blocks the pyridoxine metabolism, then you wouldn't have pyridoxine available, and then it can give peripheral neuropathy. So it is treatable because we can add up pyridoxine to all patients who have INH in a dose of 10 milligram pyridoxine for all patients who are receiving INH because of the block of metabolism of pyridoxine. Pyridoxine deficiency also causes, or INH also causes other rare symptoms like seizures, cheilitis, conjunctivitis, and sideroblastic anemia. But these are not very common. These are not very common. So you should remember that INH is isoniazid, is a drug which can cause hepatotoxicity. It can cause peripheral neuropathy, and very rarely can cause other symptomatology, which is mainly brain cerebral or blood, which is sideroblastic anemia. Okay, rifampicin and INH are often given together, and rifampicin by itself can cause hepatitis, but because rifampicin is an enzyme inducer, it can increase the likelihood of hepatitis in INH. Okay. Luckily, these drugs are very well tolerated. You have to mention the side effects, but they are not that common. If you take that 10 million now in the world are taking antituberculous, the side effects are not that common, but you have to be aware of them. You have to be aware of them. These drugs are very well tolerated and they do wonders in tuberculosis treatment. Rifampicin is called the red drug, okay, the red drug, meaning that it causes orange discoloration of excretions from tears. They become orange-like. Saliva can be orange-like. Even urine becomes orange-like. Sweat can be orange-like. So that is one of the problems with rifampicin. But this has no pathological significance. Okay. Hepatitis is, as we said, there is rifampicin can occur. All right. And so it is a drug which is an enzyme inducer. The major problem with rifampicin is enzyme action. Okay, why? Because if a lady is taking oral contraceptive steroids, the metabolism of contraceptive cells becomes so fast that there is no contraception. Okay, a lady can get pregnant easily if she's taking oral contraceptive and rifampicin because of the enzyme induction. Okay, other drugs which interact with enzyme induction is, if you have warfarin, then becomes, ineffective or very fast metabolized, and then you have vitamin D effect. Okay, if you have fast if you have metabolism being enhanced of vitamin D, as you know, vitamin D is metabolized in the liver in its first arm, and then in the kidney in the second arm. In the first arm, vitamin D goes to 25 hydroxycholecalciferol. Okay, this part of the liver gets, metabolized quickly, and you get a deficiency, relative deficiency of vitamin D. So in the long term, patients who are taking long-term enzyme induction has to be supplemented with vitamin D. So the problem with rifampicin is that it is a strong enzyme induction. It can also cause red coloration, but it can also cause hepatotoxicity and some other rare complications. Okay, the third drug is pyrazinamide. Pyrazinamide. And by the way, pyrazinamide is a sterilizing drug. Its effect is not primarily, it is a sterilizing drug, pyrazinamide. So if you have two effective drugs, rifampicin and INH, then you have a sterilizing drug, it helps. And ethambutol, which is the fourth drug, ethambutol is a drug which will help to prevent resistance. So you have two major drugs, and pyrazinamide and ethambutol are helping drugs. One of them is sterilizing drug, pyrazinamide, and one of them is preventing or helping not to develop resistance. Pyrazinamide is hepatotoxic. Okay, if you ask me which is the most hepatotoxic among the antituberculous, is pyrazinamide. Okay, but it has other effects, gastrointestinal things like. But they have one effect which often comes in the MCQs is hyperuricemia. Pyrazinamide is a cause of hyperuricemia. It causes arthralgia, okay, bone aches, and definitely gout. If you have a patient who is taking colchicine for gout or allopurinol and you give them pyrazinamide, then you may have trouble increasing increasing the likelihood of having an acute gouty attack. Pyrazinamide. Okay, if we talk about so doses, INH is 5 milligrams per kilogram body weight. The maximum you give is 300 milligrams. Okay, rifampicin is 10 milligrams per kilogram body weight, and the maximum is 600 milligrams. Pyrazinamide is 25 milligrams per kilogram body weight, and the maximum is 2 grams. Ethambutol, you should not exceed 25 milligrams per kilogram body weight. Preferably give 15 milligrams per kilogram body weight. And this is because there is neuritis, retroretinal neuritis. It's an optic neuritis. It's an optic neuritis and can be caused by ethambutol having been in a dose of more than 25 milligrams. So we never reach 20 milligrams. So better restrict yourself to ethambutol 15 milligrams per kilogram body weight only. Okay, the neuritis which can develop can manifest one by color blindness. It's usually green-red color blindness. And you remember we test green color blindness by Ishihara chart, okay? People will not see the green as green and will not see the red as red. Okay, this is an early sign, which is important. The second one is central scotoma. You have the field of vision around it, but the center, when it becomes black, it becomes central scotoma. So you don't feel, you only feel or see on the peripheral, but that is another dangerous thing which we should be avoided. It should be avoided, and usually it doesn't occur except if the dose is very high. We don't need to have more than 15 milligrams ethambutol. So this is the thing. If you are to remember, INH can cause peripheral neuropathy, partially hepatitis. Rifampicin can cause discoloration of secretions and can cause hepatitis. but the major problem is an enzyme induction, enzyme inducer. Pyrazinamide can cause bone aches, hyperuricemia, but it can cause hepatitis, okay, or hepatocellular damage. Ethambutol can cause neuritis, okay. Ethambutol can cause neuritis when the dose is more than 25 milligrams per kilogram body weight. Okay, uh, these are the four drugs. You take four drugs: rifampicin, INH, isoniazid, pyrazinamide, and ethambutol. Pyrazinamide, and you take all these four drugs for 2 months, and then the two major one, which is rifampicin, INH, for 4 months. So the total is 6 months total, except in tuberculosis, meningitis, and bone meningitis, bone tuberculosis like POTS, or tuberculoma of the brain. This will extend from 6 to 9 months. And this is generally agreed now as the drug of treatment for tuberculosis as for today. Okay, you may find other regimes, but this is up to WHO 2017. Okay, so MDR TB is resistance to rifampicin INH, XDR, which is extensive or extreme resistance when you add to these two fluoroquinolone and an injectable antituberculous. Okay, and then total is for everything. It's resistant to every tuberculous antituberculous which is known. Okay, nowadays there are, if these are, if we get resistance to these drugs, we can go to what we call second line drugs. Second line drugs, imipenem, okay, ethunamide, imipenem, ethunamide, delamanid, okay, and cycloserine, levofloxacin. I'll just give you the names if you remember them. Levofloxacin, cycloserine, ethionamide, amikacin, delamanid, and ethambutol can still be used in second line. So these are the second line drugs, and nowadays we may need it for MDR, which is the resistance, multiple drug resistance, or we may need them certainly for XDR, which is extensive resistance. So, in summary, this will finish up the tuberculosis. If I am to summarize, this is tubercle bacillus, which is Mycobacterium tuberculosis. We have Mycobacterium bovis, which is contracted by milk, raw milk. But you remember Mycobacterium bovis, we derived the attenuated bacteria to give the BCG, the vaccine. Okay. Early diagnosis is very important. Beware of resistance of tubercle bacillus to drugs. Okay. Multiple drug therapy. All right. Four for 2 months, and 2 for another 4 months. This brings the difficulty in treating tuberculosis with very close observation. We used to use DOT, but directly observed treatment is no longer being recommended. We have other ways, electronic ways and online, like video vaping, all right, SMS, all right. So other ways of treating. But you have to remember that in 1986, HIV when came changed the whole concept of tuberculosis, and the picture of tuberculosis has changed. Uh, the clinical picture has changed. Response to treatment, although now we just stick to the drugs prescribed for non-HIV, it is the same, but recurrence is not that rare with HIV, and this will pose some problems. So HIV and tuberculosis closely associated, and they have to be observed. Okay, ART has to be given, and if you start anti-tuberculous in an HIV, don't start ART except after 2 weeks. After 2 weeks, but HIV plus tuberculosis is a lot of drugs. ART is multiple drugs, tuberculosis is multiple drugs, and we need multiple care, multiple observation for these patients to continue taking the drugs despite the large number. Compliance always decrease when you have a large number of drugs. Nowadays, luckily, we are combining. We have a one bill combination of 2, 3 drugs in one bill, which will make it easy to swallow and which will increase the compliance. So with that, I think if you go and read about tuberculosis, I think this will be a good foundation for you to increase your knowledge about tuberculosis. Thank you very much indeed.